Welcome to this explainer. Today we're basically going to play the role of medical detectives to decode the seemingly chaotic world of nystagmus. Look, if you've ever stared at a patient shaking eyes and felt completely overwhelmed by all the dense clinical terminology, you are in the exact right place. We're going to take this complex topic and make it incredibly easy to understand using some really high-yield frameworks and cheat code mnemonics. Let's dive in. Here is our roadmap for the investigation today. We'll start by defining the eye movements, look at the normal variants and their mnemonics, decode childhood nystagmus, navigate adult-acquired cases, learn to spot the imposters, and then wrap it all up with a final exam challenge.
All right, Section 1, Defining the Eye Movements. Let's lay down some basic detective groundwork so we're all speaking the exact same no-jargon language.
Before we get into the weeds with any complex charts, we have to define a few key identifiers. Manifest simply means the shaking is always there, it's constantly present. Latent, on the other hand, means it's hiding until our binocular fusion is broken, like for example when you cover up one eye. Furthermore, conjugate means both eyes are moving together in sync, while disconjugate means they're moving differently. Keep these terms in your back pocket, you're going to need them.
Now, let's talk about the actual movement. Pendulum nystagmus has equal velocity in both directions. Think of the smooth swing of a grandfather clock. Jerk nystagmus, however, is a whole different beast. It features a slow, defovating drift where the eye literally slips off its target, followed by a fast, refixating snap right back. And here's a massive, absolutely crucial high-yield tip. We always name the direction of jerk nystagmus after that fast snap.
So, how do we organize all this? We can confidently split every single nystagmus case into two main buckets. First, physiological, which are completely normal, healthy responses. Second, pathological, which actually indicate a disease process. Those disease processes are then broken down by whether they show up in childhood or are acquired later on in adulthood.
Section 2. The normal and the mnemonics. Let's look at the everyday eye movements that don't indicate any underlying disease whatsoever. First is optokinetic tracking, or OKN, which is a mix of a slow pursuit and a fast jerk, or saccade. We actually use this to check vision in preverbal kids or, honestly, to catch malingerers faking vision loss. Next is end-gaze nystagmus. This is just a completely normal, fine jerking you see only when someone looks really far to the side. Finally, there's the vestibulo-ocular reflex. This is a normal response we induce medically using the caloric test by stimulating the tympanic membrane in the ear. For that ear test, let's lock in your very first cheat code mnemonic, cows. When you put cold water in the ear, the fast phase of the jerk jumps to the opposite side. But when you put warm water in, the fast phase jumps to the same side. Cold opposite, warm same. Cows. It really is that simple.
Moving on to Section 3, Decoding Childhood Nystagmus. Let's shift our investigation to the pathological types that show up early in a kid's life. First up is infantile nystagmus syndrome. This can be idiopathic, meaning we don't really know the cause, or it can stem from sensory deprivation like albinism. The absolute crucial takeaway here is that these kids do not experience oscillopsia. What does that mean? It means the world isn't physically shaking for them. To cope, they naturally tilt their heads to find a null zone, which is just a fancy way of saying an eye position where the shaking minimizes. This shaking decreases with convergence, sleep, and strangely enough, contact lenses. Sometimes it can even be treated surgically with the Kestenbaum procedure.
Next on our list is spasmus nutans. You've got to remember this classic triad, torticollis, or a tilted neck, head nodding, and pendular nystagmus. You can memorize this with the acronym shaking necks, halt totally. Shaking necks reminds you of the head nods and the tilted neck, and halt totally reminds you of the absolute best part. This condition thankfully resolves completely on its own between ages 2 and 8.
Let's compare two really distinct childhood presentations. Latent manifest nystagmus hides until binocular fusion is broken. Literally, it waits until one eye is covered up. When that happens, the fast phase beats toward the uncovered eye. Contrast that with nystagmus blockage syndrome. Here, the nystagmus disappears on adduction, meaning when the eye looks inward. Because of this, a child will intentionally cross their eyes, developing bilateral esotropia to physically block the shaking from happening. Recognizing this trick is a major key for differential diagnosis when you're trying to rule out congenital esotropia.
Section 4. Navigating adult-acquired nystagmus. The critical point now is shifting our detective work to these adult-acquired forms.
So, vertical nystagmus in an adult is a massive red flag because it usually points to a specific neurological lesion in the brain. Upbeat nystagmus, where the fast phase snaps upward, often means a cerebellar or brainstem issue. Now, if it's only happening on upgaze, you should immediately think phenytoin toxicity. Conversely, downbeat nystagmus heavily points to a lesion at the cervical-medullary junction. The highly tested association you absolutely must know here is an Arnold-Chiari malformation.
If you're worried about mixing up that brain matrix, don't be. Just think of this fun phrase: pups usually play, dogs are calm. POUPS stands for phenytoin, causing an upbeat phenomenon. DOGS stands for downbeat, linking to Arnold-Chiari. Pups and dogs will save you on test day, I promise.
Beyond vertical, we have some really wild special types. Gaze-evoked nystagmus beats toward the direction of gaze, and it's super commonly caused by alcohol. Seesaw nystagmus is wildly dysconjugate. One eye literally goes up and twists in, while the other goes down and twists out. This points straight to paracellular lesions near the pituitary gland. Then there's ataxic nystagmus, seen in MLF brainstem lesions, where the abducting eye shakes. Finally, convergence retraction. This is where the eyes co-contract and physically pull back into the orbit on upward gaze, a classic, unmistakable sign of pineal tumors in the midbrain.
Let's anchor all those dense clinical terms with our final set of cheat codes. Seesaw's play around parks reminds you that seesaw equals paracellular disease. Converging pines connects convergence retraction directly to pineal tumors. And inaction perfectly links INO to ataxic nystagmus.
Section 5. Spotting the imposters. Our detective toolkit is basically complete, but we have one major blind spot to address.
It is absolutely critical to ask yourself, if you see a patient's eyes shaking in the clinic, is it guaranteed to be true nystagmus? The answer is a resounding no. True nystagmus must be rhythmic. These nystagmoid movements we're looking at here are the imposters because they are non-rhythmic. Ocular bobbing features irregular, jerky downward movements seen with pontine lesions. Opsoclonus is completely chaotic, multidirectional darting, often indicating encephalitis, and oculopalatal myoclonus physically couples eye movements with facial muscle twitches. Remember the golden rule of our investigation: non-rhythmic equals not true nystagmus.
All right, Section 6, the final exam challenge. We've laid the groundwork, categorized our suspects, and memorized our cheat codes. Now it's time to put your skills to the test. Here's your question. Which type of nystagmus is characteristically seen in a patient with internuclear ophthalmoplegia, or INO? Are your options A, seesaw, B, ataxic, C, spasmus nutans, or D, downbeat? Go ahead and pause the explainer right here if you need a second to lock in your final answer.
Okay, let's see how you did. If you chose B, ataxic nystagmus, excellent job. As we just covered, INO is caused by a lesion in the MLF, the medial longitudinal fasciculus. Because of this lesion, the adducting eye cannot turn inward, which forces a characteristic ataxic nystagmus in the opposite abducting eye. And of course, if you remembered our mnemonic, in action, that proves right away that INO equals ataxic.
You have done an incredible job navigating a highly complex topic today. As you continue on your medical journey, I want you to remember that the eyes are quite literally a direct window into the brain.